For me, it's a milestone that Garfield now has reached the enrollment target, and that is more than 57,000 patients. It's a milestone on another landmark within the entire project, because now we can focus on outcome. We started already doing it, but now we have the cohorts complete. Next year we have the one-year outcome data available for all cohorts, and also now we can start focusing on two-year outcome and so on and so on. So it's another several years ahead of us providing outcome data, and that is an exciting journey. Within the last 5 years, we have seen a significant uptake of anticoagulation therapy over time. That was also mainly driven by the latest release of the ESC guidelines in 2012, and from then onwards in particular there was a market increase in general, thereby slightly replacing antiplatelet therapies. And there was also a shift over time with regard to the uptake of the novel or anticoagulants when compared to standard of care, which has been so far only vitamin K antagonists. But nowadays we have two modalities, NOACs and VKAs, and the VKAs have started being replaced by the novel or anticoagulants. The significant increase from 4 to 64% of prescribing NOACs over the last few years has been mainly driven, first of course, that's trivial, by the availability. But second, based on the evidence which has shown that these compounds are safer when compared to standard of care. This is very reassuring. It is mainly a safety issue because intracranial hemorrhages have been significantly reduced by these compounds, and here we can speak in the plural form because that has been shown for any novel or anticoagulant. But it's not only then the final question of safety but also of convenience, because warfarin and other vitamin K antagonists are very cumbersome to be provided to the patients. They need individual lab control and individual dosing, diet restrictions, many restrictions with regard to concomitant therapies, and so on and so on. And the vast majority of these limitations has simply been taken away by the development of the novel or anticoagulants. The relative significance of countries, care setting, and also patient characteristics in regard to the prescribing pattern is great. Most important, which may not change so fast and maybe not in the near future, is that the care setting has an important influence what type of anticoagulants are prescribed, because we saw a significant pattern with regard to care setting. For example, if the doctor is based in hospital or the emergency care setting, when compared to cardiologists, there's much a higher chance that the patients are prescribed with vitamin K antagonists instead of the novel or anticoagulants. The patient characteristics, for me as a clinician, that is most interesting, and I think an issue where we need to work on in next upcoming educational activities, because, for example, chronic kidney disease, diabetes, and other patient characteristics again have a significant influence on the prescribing pattern of the type of anticoagulant therapy. And that, I think, is an interesting feature, because we can work on this in the future by analyzing the reasons behind and perhaps providing more data to analyze for the reasons. For me, the most important take-home message from the presentation on prescribing patterns was to learn that challenging patient populations, such as patients with chronic kidney disease, diabetes, and other concomitant diseases, have a higher chance to get VKA for antithrombotic therapy when they are suffering from AF. Why is it the case? I really don't know, because we have first evidence from subgroup analyses from the phase 3 trials where all these novel or anticoagulants had been compared against warfarin as a vitamin K antagonist, that the NOAC prescription was fine for the patient. Safety was good, tolerance was, in general was good, and also efficacy was good. What we had neglected in the past, that for these challenging patients, also the outcome rates, the negative outcome rates, went up with standard of care. So what we have learned from these subgroup analyses, that standard of care is not optimal. And now we need to implement this message into real world and perhaps find out why the doctors are still reluctant to use these compounds in challenging patients in real world. In particular, as we have special dosing recommendation for these patients for the NOACs, for chronic kidney disease, that we can use, and these special dosing recommendations are not in place for vitamin K antagonists. Well, that is my key learning message. We had the privilege for Germany to get subgroup analyses for our country from the Garfield database, and were able to compare these data towards the global patient cohort. We had seen that our patients are a little bit older and sicker with regard to concomitant risk factors when compared to the global data, and this results in a higher CHA2DS2-VASc score. In Germany, we have seen that the uptake of NOAC was very fast. We started very early, but this may have been an issue because of reimbursement. But it has significantly also increased over time. When compared to global data, we have in general a higher percentage, relative percentage of use of NOACs when compared to vitamin K antagonists meanwhile, and that is much more markedly pronounced when compared to the global data.